Hi, everybody. Welcome back. I hope you guys are all doing well. So today we're talking about defining mental disorders, kind of how we got to be where we are today. So how mental illness is understood and defined has significant social and political implications. So if I say psychiatric nosology, you guys at this point know that I mean right. So the classification of mental disorders. So the psychiatric nosology, the way that we classify mental disorders, is central in debates over mental health policy, huge in patient identity politics, and also central to the professional authority and legitimacy of the field of psychiatry itself. So there were three key areas of sociological research on psychiatric nosology, or classification of mental disorders. So medicalization, the turning of things that aren't necessarily medical into medical problems, diagnostic practices, and patient identities. And so this makes sense because we can kind of think of this as like the three different levels of sociological research. We have like the macro level, structural forces of medicalization. Then we have the people who are being impacted by that, who are then diagnosing the patient. So we kind of have like a micro, meso, micro there. If we think about medicalization, who's doing the diagnosing, and then who's on the receiving end of the diagnoses. So as we move forward, I want you guys to always keep in mind, what is a mental disorder? What is normal? What is pathological? And where and how do we draw the line between the two? And then who decides on what basis these decisions are made? Should it be patients who decide what's pathological? Should it be patient advocacy groups that decide where we draw the line? Or should it be the APA, the American Psychological Association, who decides what is normal? And so how these questions get answered has spiraling ramifications for discrimination and for stigma, for recognition and access to resources, and for identity and the very meaning of suffering. Okay, so we don't know nearly enough about mental illness and mental health. This is why I've been telling you guys that in this class, my goal isn't to say sociology is better, or that we shouldn't attend to biology, or we shouldn't attend to psychology. That's not my goal. What I'm trying to get across to you guys is that we need all of these fields to get a full understanding of mental health, mental illness, and what shapes and defines that experience and those diagnoses. And so to this point, we typically don't have a lot of discussions across fields between biology, psychology, and sociology. And because these fields aren't typically in conversation with each other, at least not all three of them, we don't have a full picture of what causes and reproduces mental illness and mental disorders. Psychiatry, which is not too surprising, has an important role in establishing behavioral norms. And so the way that we think about what's normal, what's okay, what's appropriate, what's inappropriate comes from psychiatry, but we still don't know everything. The way that we understand diagnoses really is susceptible to outside influence. And so if we think about the people who are doing the diagnosing, if we think about doctors and practitioners, yes, they try to be objective. Yes, they have, swore oaths to do good for the community, but also they're impacted by social factors, their own outside interests, and then interest-based lobbying. So even though there are individual decisions being made about who gets diagnosed with which disorder, there are also macro level structural forces impacting who does the diagnosing and how that diagnosing gets done. And not only that, but the definition of what a mental disorder is has changed. And we've talked about this. And in lecture 2, we'll talk about this even more. And so today, mental illness is typically viewed through a biomedical lens of medical illnesses. We think that mental health is about brain chemistry, chemical imbalances, very biological, very medical. And as you'll learn this semester, sure, chemistry is a part of it. I won't deny it. And I mean, no reputable researcher would. But we're also going to talk about how important it is to take the social into account. So, psychiatric nosology. Again, the classification system of mental disorders was an afterthought for most of the history of American psychiatry. This probably sounds strange to you, because if I say, I'm going to a psychiatrist, your thought, assuming that you're familiar with mental health or treatment, a psychiatrist, what do? They give you a diagnosis, and then they give you medication for that diagnosis. Or you come to them with a diagnosis and they give you medication for that diagnosis. And so the way that we think about, the way that I would explain, I mentioned I have a background in psychology. I considered going into psychiatry over psychology. And whenever people would say, well, what's the difference? I would say psychology is therapy. Psychiatry is medicine. Psychiatrists are doctors. They prescribe medications. Psychologists do therapy. They talk about your mood. That's kind of how I used to think about it. And the fact that I thought about it that way, that's not just unique to me. That's the paradigm. Psychiatry is about classifying and diagnosing a disorder and then treating it with medication. So when I tell you guys that classification and diagnoses weren't always a part of mental illness and psychiatry, it might be hard to believe, because that's the only way that we understand psychiatry now, is meds and diagnoses. But early on, prior to the DSM-3, I'll explain, don't worry. Earlier on, through much of American psychiatric history, classification systems were primitive. Diagnoses were not important. And so now we have hundreds of diagnoses that a person can have. The earliest classification systems only had one classification: idiocy or insanity. And so there were people who were normal, and then there were the idiots and the insane who were lumped together. And that was the classification system for much of American psychiatry. Hospitals, mental hospitals, which today, whenever you go to a mental hospital, they're going to be concerned with your diagnosis, the therapist you've seen before, the psychiatrist you've seen before, the therapy you've had before. For most of the history of American psychiatry, mental hospitals didn't even care about your disorder. They grouped you according to how disruptive you are. So you could have somebody with mood disorders and personality disorders and chemical disorders, all mixed together, and they're mixed together because they're not disruptive or they're very disruptive. And so in 1917, the National Committee of Mental Hygiene and what's now known as the American Psychological Association developed the first standardized classification. But it's not that it came out of nowhere. There's a reason that this happened. So the first two DSM, the Diagnostic and Statistic Manual. Remember I mentioned to you that the DSM is basically the mental illness Bible, in the sense that it's the classification system. And the fact that I even think about it that way is a testament to how important psychiatric nosology has become to understanding mental health. The first two Diagnostic and Statistic Manuals, the first two DSMs, were not really that important. DSM-1 was tiny, and it was all about psychoanalysis. So if you think about Freud, the Oedipal complex, the idea that girls want to date dad or date guys like their dad, the Electra complex, the idea that boys want to kill their mothers, the Oedipal complex is that I think boys want to kill their mothers or kill their fathers, to be with their mothers. And I believe the Electra complex is that girls date men like their fathers. And things like, if you don't, breastfeed for long enough, you'll get an oral fixation that develops into cigarettes and obsessive behaviors. Or the theory of penis envy that Freud had, that says that girls basically always see themselves as inferior to men. And the reason we have gender inequality and stress around gender is because girls want to have penises like boys. So stuff like that. And if you're familiar with this, you're like, oh yeah, there we go with that. If you've never heard of this before, it probably sounds a bit extreme, and we can talk more about it. I'm not going to go into the history of psychology and psychoanalysis because this is a sociology class. However, if you are interested in learning more about psychoanalysis or Freud or the history of psych, let me know and I'd be more than happy to do like a special lecture or have office hours. But all you need to know was the first DSM was tiny and it was based on psychosexual neuroses, basically. DSM-2, still about neuroses, about maladaptation. So your mom didn't hug you enough and that's why you hate women, like that kind of thinking. What DSM-2 did was that it eliminated the use of reaction in labels. So in DSM-1, a person would be said they have a schizophrenic reaction. So it's an action, it's a doing. In DSM-2, they took that out. And instead of a person, having a schizophrenic reaction, now the person is just a schizophrenic. And so the DSM-2, it wasn't very impactful, but it's worth noting that this was a shift from mental illness as an action, having a reaction to something, or mental illness as being, having a label. So not a schizophrenic reaction, but hey, they're a schizophrenic. He has schizophrenia. So that was the difference. But again, neither had a huge influence. Most psychiatrists through the 1800s, most of the 1900s, or at least 50s, 60s, 30s, 40s, 50s, 60s, could practice psychiatry without even attending to the DSM. They weren't important. They weren't highly regarded. Like if a psychiatrist does not adhere to the DSM today, they will be considered illegitimate. At this time, a psychiatrist didn't even have to touch it. And actually, if a psychiatrist used the DSM at this time, they probably would be seen as less legitimate because they didn't matter. Okay. Now, what happened then is there was an anti-psychiatric movement. I'm going to give you a spoiler and then I'll roll back and explain what happened. The DSM-3 was a way to legitimize psychiatry. DSM-1 and 2 didn't really matter much to people. They weren't taken seriously. DSM-3 was created, ta-da, DSM-3 was created because the field was lacking credibility. And so in the late 1960s and early 1970s, psychiatry underwent a period of professional crisis. There was an anti-psychiatry movement. And so there were a couple things that psychiatry was being accused of. One, they were being accused of being more harmful than helpful. The examples that were given were that the conditions of mental hospitals were horrible and inhumane. Treatments like lobotomies and electroshock therapy were being used. So one argument against psychiatry was that you guys are hurting people more than you're helping them. There was a lack of trust around diagnostic legitimacy. So the Rosenhan studies are fun. So what happened with the Rosenhan studies is that healthy people or pseudo patients were admitted to a mental hospital. They were not mentally ill. However, every single pseudo patient in this study, it was an experiment to see if they'd be diagnosed. Every single pseudo patient who was healthy, mentally healthy, that went to this mental hospital was diagnosed as being mentally ill. This was a problem because what it meant is that psychiatrists could not distinguish the sane from the insane. And how, if your field is based on treating the quote unquote insane, and you can't even tell the insane apart from the sane, and you have people living in these horrible conditions, and you're giving them lobotomies and electroshock therapy to healthy people, it doesn't look great, right? So nobody really trusted their diagnostics, which again, hint, hint, that's where the DSM-3 came from, but we're getting there. People didn't trust the motives of the psychiatric field. There was a thought that they were basically psychiatrists were creating the illnesses that they sought to treat. So there was a sense that mental disorders were nothing more than myths that were propagated by the government to regulate deviant nonconformist behavior. So if you think about Mark Vonnegut's story, the Eden Express that you guys read for Tuesday, Mark was a hippie. And in the quote that I shared with you all at the end of lecture, Mark was saying, like, being schizophrenia is a sane response to an insane society. Mental illness is a myth, kind of down with the government. That kind of thinking is exactly what was happening here. People didn't trust the government. There was a sense that they are creating these illnesses to fill these hospitals to elevate themselves. The deinstitutionalization of mental hospitals also hurt the legitimacy of the psychiatric field. So the deinstitutionalization of mental hospitals was just shutting down mental hospitals, shifting the focus, shifting the care from mental hospitals and professionals to the community. The reason why this was harmful is because mental hospitals were kind of like the core of the psychiatric field, like their strongholds, their forts. And the thing is, a lot of psychiatrists agreed that these conditions were not up to par. So while many psychiatrists did support the deinstitutionalization, this weakened the field of psychiatry because the mental hospitals were really their home base, really. So that hurt them. And then further, other mental health professions were gaining prominence and credibility. So clinical psychology, clinical social work, these were becoming more highly esteemed and more credible, as psychiatry was at the same time simultaneously becoming less and less trusted. Clinical psychology, clinical social work, they're less expensive, they're less intensive, and they began to be more relied upon. And so these challenges is what led people who wanted to reform the profession, who wanted to gain legitimacy back. These challenges led them to seek alternative foundations that would place psychiatry on a more solid medical footing. Hence, the lovely DSM-3. Okay, DSM-3 was all about diagnosis. So we're on the DSM-5 now, and we have hundreds of mental diagnoses. It wasn't until DSM-3 that anybody even really cared about diagnoses. And so this emphasis on diagnosis came from Robert Spitzer and a team of neo-Kraepelinian psychiatrists. I'm not gonna don't stress out too much about remembering every single name, every single date. As long as you walk away from this lecture with a general understanding of what happened here, of general trends, that's okay. So pay attention, take your notes, but keep in mind that you're supposed to get a takeaway from this. I'm not going to quiz you on, what year was Robert Spitzer born. That's not the kind of thing I want you guys, I care too much about. But fun fact, I will say that Robert Spitzer, if you've heard his name before, he's the guy who was most famous for taking homosexuality out of the DSM in 1973. So Robert Spitzer, that's what he's known for, is taking homosexuality out. So him and a team that he led of neo-Kraepelinians created the DSM. This perspective, the neo-Kraepelinian perspective, is that standardizing diagnoses was the means that psychiatry would achieve credibility. So their idea was like, listen, people are not listening to us. They don't trust us. So we need to come up with a classification system, and that's how we'll win back our credibility. So they had a set of assumptions on the Spitzer team. One, that psychiatry is a branch of medicine. So again, whenever we say, oh, psychologist versus psychiatrist, what's the difference? Well, we typically understand psychiatrists as being medical doctors, and that's the difference. That assumption came from Spitzer's team. They assumed that psychiatry should utilize modern scientific technology and modern scientific tech. There are discrete mental illnesses, and when I say discrete, I mean that you can fit into one category and not others. And they argue that it is the task of psychiatry then to understand these diagnoses and to come up with a classification system to classify these diagnoses. So before DSM-3, the goal was to delve into the psyche of the patient and evaluate repressed feelings. Again, Freudian psychoanalysis, Oedipal complex, electric complex, oral fixation. DSM-3 and on was different because it said, no, actually what's most important is standardizing the diagnosis. So what the DSM really 3 cared about, the task force, was on increasing reliability. to this point, the issue has been it's not reliable. Remember the Rosenhan studies. There was a lack of trust around diagnostic legitimacy because you had a group of healthy people as an experiment go to a mental hospital, and just because they were there, psychiatrists assumed they were mentally ill and treated them as such. So what was going on then is there was very little to no reliability in the psychiatric field. And reliability is just the extent to which different practitioners can agree over whether somebody has a diagnosis or not. So if you take 20 psychiatrists and you have 20 psychiatrists look at the same patient, are they all 20 going to come up with the same diagnosis? Or are you going to have 5 who say OCD, 5 who say gender dysmorphia, 5 who say depression, and 5 who say borderline? That's reliability. If you have a bunch of people look at the same case, will they all come to the same conclusion? Because to this point, that hadn't been happening. And so without this diagnostic criteria, researchers couldn't even really construct samples to do further research. Because if you can't even agree on who has a mental illness, then how can you replicate experiments and studies to advance the field? So if we think about the scientific gold standard, you guys probably know this, randomized controlled experiments are the gold standard. But again, if we can't even say for sure that a sample has depression, how can we be sure that antidepressants help them or not if we don't even know if they're depressed? And so the goal of DSM-3 was to create a system where 2, 3, 4, 5, 10, 20, 30 psychiatrists could look at the same symptoms and regularly and consistently get to the same diagnosis. So this shifted the DSM-3 from a continuum, which is what DSM-1 and 2 relied on, to a dichotomy. Either you have it or you don't. Again, those discrete categories, either you're bipolar or you're not. Either you have OCD or you don't. And so even though mental illness is a continuum, DSM-3 said, actually, no, you have it or you don't. Why did they do this? Because they were trying to give themselves legitimacy. It's not like conspiracy. I mean, you can, if you don't believe me, you can look it up. This is very true. So the impact of the DSM-3, published in 1980, and it took off. The way that we trust psychiatry today is because of the DSM-3, and that was the entire goal. To establish credibility, and their way for doing so was to focus on diagnoses and classifications. And so the DSM-3 became the standard way of classifying mental health. It was the key source of psychiatric authority, and it fulfilled diverse needs. And when I say diverse needs, I mean facilitating billing coding for insurance companies, developing categories that became crucial in drug research, appealing to pharmaceutical companies, because not only can farm companies try new meds, but now there are new markets for medication. The more illnesses we can come up with, the more illnesses that farm can create, medication for. DSM codes and categories became a requirement. It was only after DSM-3 that insurance companies, billing companies, hospitals began requiring these codes. This was new. And so the revisions of DSM-3 was really a quote unquote paradigm shift to people within the field and outside the field, because it changed from let's dig into your psyche and see, how your dad not telling you he loved you impacted your relationships, which, don't get me wrong, it's important to talk about. But DSM-3 said, actually, let's diagnose you first, figure out what medication you're on, and therapy will probably help as well. So the summary from this, DSM-3 legitimized psychiatry. Now it's bigger, it's more impactful than other, and it is the standard in all facets of mental health. And the stakes of the revisions have also increased. We're at the DSM-5 now. The DSM-5, the most updated version, was released in 2022. So the most updated version of the DSM-5 was released last year. The DSM-5 task force wanted to do a paradigm shift to address issues of validity. Now remember, DSM-3 had a problem with reliability. Can we have 2 different psychiatrists observe the same person and get the same diagnosis? Are these reliable categories? DSM-5 is about validity. So are these categories even valid? Are these real? Is there such a thing as depression, as OCD, as antisocial personality disorder? So this was the issue with DSM-5. This concern came from a variety of sources. One, recent genetic and neuroscientific research suggests that mental illness is on a continuum. However, DSM-3, DSM-4, DSM-5 are all a dichotomous, you have it or you don't. But increasingly, we have research that says, no, it is a continuum. That's a problem. There's a high degree of comorbidity among these categories. What does that mean? Okay, good job. So comorbidity means having multiple symptoms or disorders at the same time. And so bipolar and substance abuse, for example, borderline personality disorder and major depression, for example, obsessive compulsive disorder and anxiety disorders, for example, PTSD and substance abuse or anxiety. And so it makes, I mean, if you think about it, it makes sense. You know, if you are being triggered by your environment because you experienced trauma, that can make sense why maybe your appetite's affected and you're sleeping more or sleeping less, or you're, you know, less interested in things that used to bring you pleasure. So intellectually, it makes sense that there's going to be overlap between trauma and depression, obsession and anxiety, for example. But diagnostically, this is an issue because if all of your diagnoses and classifications overlap, they're not really discrete anymore. And if the entire DSM-5 is based on you have it or you don't, and if you have it, that's your category. But in reality, the categories are being shared multiple times by multiple people. That's a problem. Are these even valid categories if, you know, one person can have 5 of them at a time? We also have the efficacy of drug treatment being questioned, specifically drug treatment that is derived from the DSM. And so things like, you know, children being prescribed, 7-year-old children being prescribed 30 milligrams of Adderall at 7:30 in the morning every single day of their life for years. Nowadays, we would say that might be a bit much, but the idea that you give a child the maximum amount of, you know, medication comes from the DSM. And so it's become pretty obvious that what we know from the DSM isn't the full picture. However, the DSM is treated as the full picture, despite the fact that research shows us there's actually a lot missing. So, in sum, psychiatric nosology, or the way that we classify mental illnesses, are extremely important for the profession. That's why we have people arguing over the DSM. 3 major themes arise from this history. 1, classification systems are influenced by prevailing intellectual trends as well as public opinion. The shifts in classification systems have been dramatic, and as uncertainty persists, nosology has become increasingly important in establishing the credibility of psychiatry, hence the DSM-3, 4, and 5. And so more than any other profession, psychiatry's legitimacy is tied to how it defines its disease categories. Psychiatry, I can say in my mind, I can't speak for you all, but I think it's fair to say that the fact that I feel this way doesn't come from anywhere. I was socialized into this. When I think of psychiatry, I think of diagnoses and medication. And that's being increasingly debated again for all of these reasons. There is evidence to show it is a continuum, and these categories do overlap, and we don't understand the full picture, which is why I told you guys, I'm not saying that sociology is better, that biology is bad. That's not what's happening here. I'm saying we need to look at all of these fields together because all of them contribute to mental health. Okay, let's do a quick break, and I will see you guys back in a second.